where are you going next semester, potentially? So, this is a rhetorical question and no one needs to respond. How many of you want to take either a Rhine class or a, the Apex class? My prediction is that very few of you want to take either of those classes. So now, in addition to this class meaning something for the future, the next year, this class also means something for next semester. Your other classes, your other college classes mean something for next semester, especially for URI. If you do poorly in a class, and it's up to URI's discretion, URI changes their rules slightly. It used to be a C, I think. It started out with C+. Students getting a C or lower weren't allowed to take classes as a high school student. I don't know what the rule is now, and college program, the in-state college program has exploded since we started it in 2014. So my point here is I don't know what the rules are for URI, and it's entirely up to URI's discretion to let any one of you back in the university, because at the end of this semester, you're going to get kicked out of the university, not because you did anything wrong, but because you're only here for a semester, and then you have to reapply in January. If, upon that reapplication, they're going to now look at your performance this semester, and if it's not what they think is appropriate, they're not going to let you take URI classes. And I'm not threatening you, right? I'm just telling you the way it is. So if you don't need any more motivation as a springboard for next year, hopefully you need motivation for the next semester. I was talking to my daughter last night, who is a senior, and she was late this morning. She's like, Dad, I can't believe I have to go to school. I have to play a dumb game tomorrow, and oh my God, it's just so dumb. And she's complaining about doing this and doing that. And I understand where she's coming from. I understand what you guys are going through, but you need to push through for not even a month, right? So this week, we have this lecture, mini practical, exam, and then Thanksgiving. Okay? All right. So the long term, you want to get into a good school, and you want to get whatever major, and you want to get a good job, et cetera, et cetera. The immediate term, though, the way to get there is to do what you have to do this week. Starting today, and this lecture, I'll give you a warning, not a warning, but so a heads up. This isn't going to be a very long lecture, and it's Wednesday, so that if it's not a long lecture and it's Wednesday, you're like, I don't feel like going to school, I don't feel like going to run it, I'm going to tell Ms. Benninger. So.
Really? After all we've been through?
Yes. But if you choose that, that's a bad choice, right? You have a lot of stuff to study. The performance on yesterday's quiz illustrates that everyone in this room has a lot of stuff to study. In addition, you have a mini practical on Thursday or Friday. So I just want to remind you, the way to get to that long-term goal of getting your doctorate, to getting a job in whatever discipline you want. I don't care if you're a healthcare provider. It doesn't really matter to me. But I do want you to have a career, and I want you to have options. And at some point, I want you to be able to own a house and to drive a nice car and just have stuff like that, right? But the way to get there is a series of good decisions starting today. And you can make bad decisions too. And hopefully you won't. Inevitably you're going to, but hopefully you make better decisions. All right, so I want to just talk about what I ended up talking about yesterday, which was talking about reflexes, and we're talking about information flow now. At this point, we're talking about comparing generally the central nervous system in general, but we're talking about the peripheral nervous system as well. Notice too, this terminology, integration center, effector type. What is an effector? An effector is something that receives information. An effector falls into two categories. What are those two categories? Skeletal muscle, smooth muscle, cardiac muscle, that's one category. and glands. That's the second category. So effector and then affector. Affector is the sensory information going, or afferent division, going from the periphery to the central nervous system. And that's what we're going to start talking about today. We're going to start talking about reflexes in general, and then we're going to get into more specifics about the information flow in a couple of specific examples. The most common reflex that we're going to talk about is called a polysynaptic reflex arc. And that state here, and if you look at these 5 steps here and the diagram above, the 5 steps are very, very specific, and you need to know them. And then you need to know, so this is the one that I want you to know backwards and forwards. And again, I like to ask questions. So if you're right here and it's in a reflex, where is it going to? Where is the information coming from? If you're right here, where is it going to? Where is it coming from? Etc. Right? So so not only do I want you to know the steps here, not only do I want you to be able to identify the diagram, things on the diagram, I also want you to know it backwards. I also want you to pick a spot in here and tell me what's happening next and what's happening subsequent, what happened before. And then finally, I want you to tell me how this polysynaptic reflex arc is different from others. Where would you find it, and when does it apply? So let's just start here. In terms of a reflex in general, in fact, anything that we are talking about here in our body that we respond to, it begins with a sensation, whether it's conscious or unconscious. There's some type of sensory receptor, and that, again, is an epithelial cell that's modified in its synapses with a sensory neuron, an afferent neuron, and that when that exceeds the threshold, that generates an action potential. That sensory neuron then conducts that action potential away from that source of information towards in an afferent direction to the integration center or the interneuron. This interneuron right here is shown in this very small area. This little purple area right here is the integration neuron. And if you look at just to the left, to the right of it rather, my pointer, there's a yellow arrow, and that talks about illustrates the flow of information. And indeed, that's the direction of flow for all the information that we're going to be talking about in these examples here. So it goes from the dorsal portion of the spinal cord to the gray matter of the spinal cord that then gets gets sent elsewhere, and then it goes ultimately to the ventral root. This is a simplified drawing because, in fact, this integration center, this short neuron, is going to send signals in multiple directions. First thing is it's going to send signals to this area right here. And what area am I pointing at? Not to the central canal, but to the gray commissure. If an appropriate signal needs to be responded to on the other side of the body, it has to get sent to the other side of the body, and that's what the gray commissure does. In addition, this integrating neuron sends signals here. Where am I looking at here? This is the white matter, and those white matter, there's going to be columns, or there are columns in the white matter, and those columns will be either sending in an ascending direction or a descending direction. In this case, because the signal is getting sent from the sensory neuron, it has to get sent to the ascending division. In other words, get sent to the brain. So the sensory neuron sends signals to the interneuron, and a number of things happen in the interneuron. In this case, we're only worried about that little integrating neuron, this number 3 here, which then transfers the signal or relays the signal to the ventral root and a motor neuron. That motor neuron then synapses with a neuromuscular junction with an effector, and that effector in this case is the biceps brachii. So that biceps brachii, now there was it looks like there's a bug there, and the biceps brachii, there's a reaction hitting the bug.
So in 4 it says that the interneuron synapses with the motor neuron, but it says simple reflexes do not involve. So what does it synapse if there's no interneuron?
That's a good question. That's the next thing that we're going to talk about. So for right now, for a polysynaptic reflex arc, it absolutely involves an interneuron. Most reflexes involve an interneuron. And there's a case, it's a good question, Finn, and we're gonna get to that in a second. More simple reflexes and more rapid reflexes do not involve the central nervous system or interneurons. And we'll get to that in a second. So Finn went forward and read, because the simplest reflex is called a monosynaptic reflex. The term monosynaptic means there's a single synapse, and that single synapse is between the sensory neuron and the motor neuron. In this case, an example of this example here is a muscle spindle that when it's stretched, that the sensory neuron feels the stretch, and immediately that motor neuron tells the muscle cell to contract. So in this case, this monosynaptic reflex arc is illustrated here. So the patellar tendon and the patellar ligament here, that's what we're looking at here. So this is a familiar situation for you. You're at the doctor's office. You're back when you were little, and you were small parasites as opposed to being large parasites that you are now. But your doctor hit your patellar ligament with a tendon hammer, and there was a response. That response was not planned, and you didn't think about it. It's a monosynaptic reflex arc. So the signal comes from the patellar ligament here, and it causes the quadriceps muscles to stretch. The quadriceps muscles have receptors in there, sensory receptors, and those sensory receptors then, and those are all these sensory receptors are modified epithelial cells. They synapse with sensory neurons. Those sensory neurons then go to the spinal cord. They bypass entirely any interneuron, and they synapse directly with the motor neuron. Don't worry about the alpha and beta motor neurons, just worry about motor neurons here. That synapse with the motor neuron then causes that same muscle that was stretched now to contract. So in this case, this monosynaptic reflex arc happens everything within the, between the patellar ligament, the quadriceps muscle, and then and the central nerve and the spinal cord. So it goes up the leg to the spinal cord, and it goes immediately back down. So even though the synapse happens in the spinal cord, it bypasses the spinal cord completely. So in this case, and you remember this from being evaluated in the doctor's office, you can see that if this works appropriately and you get an appropriate response, then the signaling from your leg to your spinal cord and back to your leg is working. And there's an example of a simple, the simplest reflex arc. So in this case, if you look at this diagram up here where my pointer is now, the signal is, let's see here, the signal is more, so if you look at this little bit of a diagram here, it's more detailed than what I just described. And so when the doctor hits your knee with the patellar hammer and your leg pops out like that, then your brain says, oh wow, that felt funny, or at least it does with me. And then it's like, wow, look at my foot moving. Right? So that's all of that acknowledgement of that happening is after the fact or just as it's happening. So that's what these arrows mean. This ascending sensory nerve tract that's going up to the brain. That is not part of this reflex arc. This reflex arc is very simple. The only thing, so there's only two things that are a part of it. There's a sensory neuron and a motor neuron. The effector of the motor neuron and the affector, or the sensory epithelial tissue of the effector. There's other types of reflexes too, and these are basically meant to keep the body from doing too much damage to your body.
So for instance, there's Golgi tendon organs, and those Golgi tendon organs are associated with, bless you, with near muscles and joints and other articulations. And if there's too much pressure on that joint or on that articulation, let's say you're picking up something that's too heavy, you're gonna put it down whether you want to or not, because it's too heavy and you want to prevent damage, further damage, or any subsequent damage to that area of the body. So this, an example here of a weightlifter, they want to pick up, they want to max out on their weight, and they just weren't able to do it. In this case, now, there's a new group of neurons here. I've just classified interneurons so far. But yesterday we talked about IPSP and EPSP, excitatory postsynaptic potentials, inhibitory postsynaptic potentials. In this case, the sensory neurons, these are afferent neurons going on the dorsal root ganglion, are going to the interneurons, and the interneurons say there's too much pressure there. We need to do something. We need to react to that to prevent further damage. And then those interneurons then send out an inhibitory signal. So that inhibitory signal is the exact opposite of what the previous slide talked about with the patellar tendon sending a signal to the muscle and that muscle contracting. The inhibitory, that's an excitatory signal here, and an inhibitory signal is one where there's no response. So this Golgi tendon reflex is different in that there's inhibitory signals being sent. So this is not something that you would think about, that you would do, and you're not going to say, oh, I'm normally used to picking up 125 pounds, and this is 225 pounds, and therefore you're not going to sit there and calculate this and calculate the damage to your knees, let's say. You're just going to drop the weight and try to get the hell out of the way. Right? Then you're going to say, shit, why did I do that? I wanted to pick it up. So this Golgi tendon reflex here, again, it's the same process. The main difference is that instead of initiating a contraction, a muscle contraction, or a contraction of a gland, it initiates an inhibition. That inhibition then causes the muscle not to relax, or not to contract, rather, it causes it to relax. This is another version of this same thing, removing a body or a limb from a painful thing. This is basically, you put your hand on a hot plate, you put your hand on a tack, you sit on a tack. Back when I was a kid, it used to be fun when you're in elementary school, when we have a sub, right? Take a sub, if the sub was standing up, over a substitute teacher, you put a tack on their seat and wait till they sit. Right? Yeah, you know, I was a perfect child as a kid.
Mm-hmm.
I never did stuff like that. But there is an example of a withdrawal reflex. You sit on the tack and you stand up and you start swearing. Depending on where the signal is, the signal doesn't have to be right where the reflex is. In other words, in the monosynaptic reflex, where the signal happens at the patellar ligament, the quadriceps muscle is stretched, the quadriceps muscle senses the stretching, and it immediately causes that quadriceps muscle to contract. It all happens in that area. There's other areas, you can have a withdrawal reflex where it synapses to the central nervous system, and then it says move the other side of the body. And that is another characteristic here. So this withdrawal reflex is another example here. In this case, you're stepping on a nail or a tack. That sensory stimulus. Now, in addition to this part, and here's another thing. We talked about inhibitory motor neurons a minute ago. We also have excitatory motor neurons, and we talked about those. But these things actually work together. Because if I'm walking down the street and I step on a tack, and then my response is to contract my gluteal muscles, right? And my gluteal muscles push down on the tack, right? That's going to be a problem, right? That's going to be hurt. That's going to make more damage. So what's going to happen to the gluteal muscles in this reaction here? And then there are other muscles that extend the leg. What's going to happen? Those are going to relax. Those are going to be inhibited.
and then there's going to be others that will elevate the leg that will be excited. So in both cases here, so there's excitation of certain motor neurons, there's inhibition of some motor neurons, so that you get an appropriate response. Okay. In all cases, now in this case, this is another example of a polysynaptic reflex arc. How do I know that? So if you look, if there's there's an interneuron there, in this case now it's an excitatory interneuron. There's also in this drawing, that's not shown, there's also inhibitory interneurons, and they're going to be sending signals to other other muscles. But this excitatory interneuron, if there's an interneuron involved, then it has to be a polysynaptic reflex. If there's no interneuron involved, then it's monosynaptic. I just mentioned inhibition, withdrawal reflex with reciprocal innervation, right? Inhibitory interneurons will help provide an appropriate response. You don't want to be pushing down on the hot plate if your hand is there. You don't want to be extending your arm. If this is a hot plate, you don't want to be extending your arm onto it and further damaging your body. So those extensor muscles in your biceps or your triceps muscle are going to relax. The flexor muscles of your biceps, your brachioradialis and your brachialis, are going to contract. Right? So that happens simultaneously. And again, the reason why is that to provide an appropriate response, reduce the resistance to the removal of that painful area, and to protect the body. In some cases, this is getting a little bit more complicated. I'm not as worried about this crossed extensor reflex, but if you look at the central nervous system here, from the original drawing that I had, where you had in a polysynaptic reflex, we had a sensory neuron synapsing with an interneuron to a motor neuron, and then back to that motor neuron to a monosynaptic reflex, right? In that case, there's two simple things. In this drawing right here, this is something more realistic, and it's not even this realistic. It's still overly simplified. But in this case, we have the sensory neuron synapsing with multiple interneurons. In this case, an interneuron, now if you look at on the left-hand side, there's a 2 and then there's a 3. There's 2 excitatory interneurons. And so all this is saying is it's doing 2 things at once. It's sending 2 signals out at once. And in fact, that's what's happening. It's sending multiple, your body, your central nervous system is sending multiple signals out at once, immediately, and then as a matter of seconds or milliseconds after that from the brain, you're also sending signals out. Now, if you're going to send signals to the opposite side of the spinal cord, how do you get there? Well, you have to synapse with different neurons that are going to be sending it. And one way is to, if you look at it where the drawing is, it's going to synapse with a different interneuron, and that interneuron is going to go to the opposite side of the spinal cord. Yes?
So for the cross extensor reflex, it's basically like if one side is doing something, it just does it to the other side?
Yes, exactly. Right. In all cases here, these, when they're more complicated here, they're just different variations on the polysynaptic reflex. Okay. If polysynaptic simply means it's more than one or several synapses. So now let's talk about get a little bit more detail about the spinal cord itself, and the spinal cord, in particularly the white matter here in the left-hand side of this drawing here. So we have a signal going down the dorsal root ganglion, synapsing with the spinal cord, and the effector then is the muscle, wherever that is. But while that's happening, then the ascending tract is going to be sending, and it might be on the same side of the spinal cord, it might be on a different side of the spinal cord. And so here, where my pointer is, that would be, those neurons right there are part of the great commissure. That great commissure is associated with either posterior or anterior to the central canal, and that great commissure then would be synapsing with white matter in the ascending tract. Here,
this ascending tract, always, 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 no matter what the signal is an ascending tract part of the spinal cord is always sending signals to the brain, and the opposite is true too. The descending tract is sending signals to the periphery, and again, when the periphery is either motor, muscles or glands. I mentioned the terms EPSP and IPSP. Where are they going to be coming from? What are they going to be doing? So that excitatory postsynaptic potentials, now I can add that question in as part of the reflex and sort of make it more detailed. Inhibitory postsynaptic reflexes, or postsynaptic potentials rather, will also modify a reflex and help appropriate response and reduce damage to the body. So reflexes come in a couple of different varieties, but at the end of the day, there's really only two. There's monosynaptic and polysynaptic, and there's different variations on those polysynaptic reflexes. Again, there's different ways of describing or categorizing reflexes. There's either learned or innate reflexes, and et cetera, things like that. So now we're away from the spinal cord entirely. We're as part of the peripheral nervous system, and we are either coming from the periphery or going to the periphery. We're not involved with the central nervous system at all. And as you know from the Syndaver here, when you look at the Syndaver, you can grab the muscle on the, separate the quadriceps muscle, and you can find the femoral nerve. And that femoral nerve is yellow. And that is meant to mimic this yellow or this outer layer there. And this outer layer is principally connective tissue. And that outer layer then has a bundle of neurons here, and that's bundled, and then there's an inner layer too. So there's three layers that mimic the names of the coverings of muscles. There's the epi, peri, and endoneurium. The epineurium, perineurium, and endoneurium. I mentioned the endoneurium yesterday in lecture. And the endoneurium is the one that's surrounding individual neurons, and in particular, most especially the individual axons. The perineurium then groups individual axons into fascicles. That term fascicle is what we group muscles into as well. And then the epineurium is going to be responsible for surrounding the entire nerve. In addition to the nerve itself, there's also going to be blood vessels, and so there's going to be arteries and veins. There's an additional connective tissue as well. So that additional connective tissue is basically going to keep the nerves themselves, the individual bundles of nerves, or neurons rather, from getting too much pressure on them and try to protect them. Now, going deeper from the endoneurium, so if you look over here on the left, there's the endoneurium, and then the Schwann cell. Now, in this case, if I put oligodendrocyte right here, I would be entirely wrong. Why is that? Because this is part of the peripheral nervous system. So the Schwann cell is covering the axolemma, and then the axolemma is superficial to the axoplasm. So again, now, where is that information coming from? That's coming from last chapter. We've talked about the spinal nerves in general here, and we've talked about different areas of the spinal cord. We've talked about the termination of the spinal cord here, and where is it? It's not listed, but that right there is the conus medullaris, right around there. The conus medullaris is then inferior to that is the cauda equina, and then the filum terminale is going to be, it's not illustrated here, but it's going to be rooting the inferior portion of the spinal cord to the coccyx and to the bone. Remember too, we have different plexuses. There's the cervical, the brachial, the lumbar, and the sacral. I think I just talked about the lumbar plexus and the sacral plexus. I'm not going to be worried about where they are specifically. So in other words, I'm not going to be saying, is it L1 to L4 or is it S12 to L5? Which one is it? I'm not going to be that specific here, but the lumbar plexus is the superior part of the lumbar vertebrae. The sacral plexus begins with the inferior part of the lumbar vertebrae and then down into the sacral vertebrae. These at this point, these things are spinal nerves. Right? When they're spinal nerves, these spinal nerves will diverge and then merge together, and so that some will be forming bigger ones and others will be forming smaller ones. The biggest one, right, is illustrated right here. That's the sciatic nerve. And then if you look up here in these brachial plexus, there's also brachial plexuses have things that are merging. These spinal nerves are emerging from the spinal cord, and then they're going to merge together and then branch out again. Those in the brachial plexus are going to be called cords, and there's 3 cords there. When you're talking, again, when we're talking about the spinal cord itself, it's beginning at the inferior portion of the foramen magnum or of the occipital bone. I don't really talk about dermatomal maps, but one of the things that is interesting is that dermatomal maps is just sort of the sensory area, the area that's supplied by the skin, and there's conditions, if you have, there's some skin conditions where there are rashes that will come in characteristic areas that are affected by the sensory neurons, and they follow those sensory neurons and they follow these dermatomal naps. We talk about the dorsal ramus and the ventral ramus and the spinal cord, right? So I'm not as worried about those areas. I am worried about these right here, these 4 plexuses. I didn't really talk about the coccygeal plexus. It's much, much smaller. And again, now those 4 plexuses are what we're going to focus on now. If you look at this diagram right here, now this diagram is part of, essentially, this is part of the thoracic area right here, and if you look on the diagram on the left, so we're sort of inferior portion of the thoracic vertebrae. We have the dorsal root ganglion right there. We have sensory root, and these are the roots and the rootlets right here, the ventral roots and the ventral rootlets right here, and they're going, and at this point it's called a spinal nerve. This here is a sympathetic ganglion, and a ganglion, once again, is the area of the peripheral nervous system where that has grouped cell bodies in an area, and that cell body, those cell bodies are basically bypassed by the central nervous system, by the nervous system, not the central nervous system. So the axons bypass it. They're either unipolar or pseudo-unipolar neurons that are basically allowing for the transfer of information. If you look over here on the right, you can see some rootlets here, and this is an actual dissection here of a cadaver. So here are some rootlets, and then this would be the root. And then if I were to say that this is a dorsal view of the body, and I put a pointer right there in my question here, so this is a completely unlabeled diagram right here. This is a dorsal view of a cadaver. What type of information is being sent down this structure right here, where my pointer is? Sensory, motor, integrating neuron. This is indeed sensory, right? So this is part of the dorsal root because it's a dorsal surface here, a posterior view. There's 4 plexuses, and we've already talked about them last week in lab. So those 4 plexuses begin with the cervical plexus, and that leads to the phrenic nerve. That phrenic nerve then is associated with the diaphragm. So that's the most superior nerve in the body that we need to know for spinal nerves. And it's interesting because I've told you that the peripheral nervous system is voluntary, and we're talking about innervation of the diaphragm, and there's definitely an involuntary component to this. So although I've said there's voluntary and involuntary nerves right here, there's an involuntary component. It's much, much more complicated than that. Let's see here. Going down the picture here, we're going to the brachial plexus here. The brachial plexus then has these nerves right here, these 5 nerves. And these 5 nerves then generally are going to be serving the arm, the shoulder, and then the forearm and the hands. So that's generally what we're talking about here, but we're also worried about the cords themselves. So the cords themselves are breaking off of or separating from the brachial plexus or converging from the brachial plexus. And I'm going to tell you what I mean in a second. So if you look at this picture on the left-hand side and then the terms on the right-hand side, I've told you this last week, there's three cords in the part of the brachial plexus, posterior, lateral, and medial cord. Those three cords then branch off ultimately to these 5 nerves. And if you look at the, what's the blue area? No. There is, where are the cords? Oh, here it is. It says orange cord. So here's the medial cord. Here is the lateral cord, and here's the posterior cord. Now, I want you to look right here. In this point right here, so it's really easy for me to say there's a big nerve coming off of the spinal cord, and then it branches off into successively smaller and smaller parts, and it never reemerges. But in fact, that doesn't happen. It's a good deal more complex. So in this case now, we have spinal nerves coming off of the spinal cord, and so these are, for instance, C7 and C8. So there's inferior portion of the cervical vertebrae here, and indeed that's where we're talking about in the upper portion of thoracic vertebrae. So now they come off here, they branch a little bit there, and then there's the posterior cord, the lateral cord, and the median cord. In this case, there's the medial cord and the lateral cord then combined to form a single nerve, and that single nerve is the median nerve. So there's in a case where instead of it just separating and getting smaller and smaller, they then merge, and then they then diverge from there. So in terms of the nerves themselves, the things that you need to know the axillary nerve, the radial nerve, the musculocutaneous, the median nerve, and the ulnar nerve. Now, I won't ask you for identifying this diagram right here, which nerve is it at this point. I will ask distally from there. But you should know the 5 branches off of the brachial plexus. You should know which cord feeds which of these nerves, or cords. Because in lab I said it's a good deal, the median nerve is more complicated. So for instance, the ulnar nerve just is fed by the medial cord. The lateral cord is just feeding the musculocutaneous, but together they feed the median nerve. So that's what I mean there. So in some cases, there's a single cord separating to form a nerve. In other cases, it's more complicated. Yes.
So, so are like cords, where the nerves like intersect?
So no, this is not where the nerves intersect, right? So what this is doing is there's just branches of the epineurium, endoneurium, and perineurium, right? That are groups of axons right here, and they're separated. Sometimes they separate into smaller divisions. Other times they combine to make bigger ones. In this case, where we're talking about right here, right here, at the median nerve, you have 2 smaller groups of nerves that are then merging to make a larger group. And as it's merging, it's going distal from there. And so most of the times they separate and they get smaller, but sometimes they combine and get bigger. And by the way, if you want to look at so this drawing on the left-hand side is what I'm focusing on. It's a little bit more complicated in real life. Look at this. It gets really, really rough. The brachial plexus. Let's continue on here. The brachial plexus here. What is the first nerve that we're talking about? First of all, it's the axillary nerve. And where are we coming from? We're coming from the posterior cord. That posterior cord is feeding the shoulder essentially here, and 2 examples of the shoulder muscles there include the teres major, or teres minor rather, and the deltoid. So what I would ask for that one would be, which of the following nerves help move the shoulder either forearm circumduction or adduction. Abduction, sorry. The radial nerve, now where am I going to ask in terms of the practical? Here, I'm not going to ask them for the radial nerve. If you look right here, here's the radial nerve emerging from the posterior cord, right? But the radial nerve also, if you follow it down, it's got a bunch of different branches, and it is associated with the, and it's not labeled here, but it's associated with the radius. So what are some examples of the, so first of all, it's coming from the posterior cord. It does a whole bunch of stuff associated with the muscle, with the arm. And it is particularly interested affecting the lateral hand. Now, where is the radial nerve? It's lateral. Where is the radius? It's lateral. Where is the impact of the radial nerve? And if you look at this diagram right here, the blue area right here, particularly on the hand, the lateral portion of the hand. Musculocutaneous nerve is also part of the lateral cord. Musculocutaneous nerve is going to be, is really going to be part of the upper arm, the distal part of the upper arm. In other words, the elbow area. The ulnar nerve is coming off of the medial cord. The medial cord then is, its name median, is medial. That medial area right here is going to be feeding the area of the hand, and I'm particularly worried about, for these three nerves, the hand muscles here. So we're worried about the medial portion of the hand, and we're talking about the phalanges 4 and 5. And indeed, this is what, if you look at this diagram right here, this blue area right here, this is what we're talking about, phalanges 4 and 5, are what impacted by the ulnar nerve. And then the median nerve, which one does it impact? This one. So the median nerve is branching off of the combination of the lateral and the medial cord. Right here, it comes down the forearm right here, and it goes right down the midline of the hand, so that it is really easy for me. If you have three of the nerves right here, the one associated with the lateral is the radial nerve, the medial is the ulnar nerve, and the one in between is the median nerve. Again, now this median nerve is going to be serving principally the hand here, particularly the some of the thumb, and some 1 and 2 flange, but also flange 3. And this is going to be a nerve that's impacted by the carpal tunnel syndrome, called a retinaculum. So now we go to